हाँ सर।
Good evening. Good evening, Rahul sir.
हाँ।
Dr. Dixon, Dr.
Ma'am,
Arun.
good evening, ma'am. Hello, good evening, sir. Welcome.
Good evening, madam.
Yeah.
Good evening, sir. Yeah. So, often what we do is, ma'am, we start sharp at 8 o'clock.
Okay.
So we have a very brief introduction. It will not be an elaborate discussion. Introduction. And the student speaks about 20-25 minutes uninterrupted. And then we invite the statistician to speak about the statistical part involved and what are the difficulties that could come through during the study. And then you and sir will take turns to critically appraise the presentation and some words of appreciation for the student on his presentation, which will be followed by what are the drawbacks of the study and what are the merits of the study and how this study, how this study can change the practice locally for India, how it can make a significant impact. And there will be a set of Q&A which will be coming through the chat box. We will be taking up one after the other. and either the student or if it is from the study, the student, or if it is if it is the in general, you can take the question. The panelists can take the question.
Okay.
Yeah.
So you will be introducing the students, and once the
I'll be
student,
introducing the panelist and the student, and once I introduce the student will start. He should usually end by 8:25, 8:20, 8:25. The statistician usually finishes her topic by 8:35, and then we have about 20-25 minutes left for the Q&A.
oh, fine.
The entire session would be recorded, and the edited video gets uploaded into the ISN website now. So this is an ongoing monthly ISN journal club. So we often rotate between the zones. South zone. This month it is the South zone, and every third month we do 3 months in nephrology. So we discuss some of the important articles which were published in nephrology journals in the last 3 months. So every month it goes to a different zone, and this term it's the South zone. So the panelists as well as the student will be from the South zone.
Yeah, thank you. I think it's a good initiative, and the rotation is also a good idea, so that all the the chapters are covered, and it's not like one zone is neglected.
Right. Thank you.
And it's been regularly happening for how
Yes.
many months now?
It's close to 18 months, ma'am. We started in 2023.
Good.
It's
So
close to 12 months.
12 months.
12 months.
Around 10 months we have done, ma'am. From I
Okay.
think August 23 we had started.
Okay. So, I mean, these, like, we have 4, is there a committee for this journal club, exclusive committee for people?
Yes, ma'am. I mean, we just discuss what are the articles to be selected for that month, and the panelists and the speakers.
Okay.
And we tried to select. I mean, we had students from Guwahati Medical College talking about. Speaking at the journal club. So we try to involve all the students across India, and we have a prefix template, how like a background, what are the previous studies in the particular topic, and how the drawbacks of this study. So we have a particular template, and students usually prepare their slides on that, and then we have a statistician or a subject expert. Someone previously we had studies in which the authors were invited. We had one study from Madras Medical College, and Gopal Krishna sir and his team were there as the people involved in the study. So either we have people who conducted the study or statistic inputs. So one of them will be other than the subject expert.
I think that was a great idea of introducing a statistician also in this discussion.
Yeah. Yes.
I think the student is
Hi.
here, and
Dr. Prasoon, can you just share your slide and just check your audio and video also?
Okay, madam. Okay, madam.
So Padmanabhan sir, anything from your side, sir? Any questions you have for us before we start the meeting?
Hello, you're able to hear me?
We are able to hear
Yes,
you.
sir.
Hi.
sir, good evening, sir.
Hi, good evening. Good evening.
Sir, I think
So,
some lighting issues, sir. Not able to see your face clearly.
I think so. This light is exactly opposite.
Prasoon, you're able to share the slides?
No, sir, actually. It was showing that you cannot start screen share while other participant is sharing.
Rohit, can you just stop the posters sharing? Yeah. Now you can do it.
Okay, sir. Is it visible now?
Yeah, it is.
but
Slides are visible, Dr. Prasoon.
Okay, thank you, sir.
please move your slides. Sometimes it gets stuck.
Hmm.
Yeah. Yeah, wonderful. It's moving now.
Another 2 minutes, ma'am. Another 2 minutes. We will be starting at exactly at 8.
It's sad that Dr. Bakris is no more with us.
Yes, sir. We just thought we'll also have the condolences with that.
Yeah.
He's one of the authors of the study, and I thought I'll include it in my introduction when I speak about that. Yeah.
Hi, Dr. Swanlata, Dr. Padmavan, welcome.
Hi, Dr. Sham. How are you?
Yeah,
Mm.
how are you?
Good.
Thanks for joining. As a
Hi. Thank you very much.
Yeah, thanks for the opportunity, sir. Just now we were discussing that these journal clubs are very useful to the students.
Yeah, Arun and Darshan, they are doing good work, great work, and they are doing all the coordination and everything. And so I think it is going on well. The people are participating, students are participating, and it's really useful for a lot of people who are not involved in day-to-day academics. So I think that's a good response.
Yes.
That highlight is statistician coming in.
Yeah, so we try maybe
We are having a statistician on board. So Dr. Arpita Ghosh is there. I think she will be presenting us about the randomization part after the student's presentation.
yeah,
So
that's
that is something that we are all lacking.
so Arun or Darshan, can we
I'll
start?
start it.
Yeah.
Yes, we can start.
Good evening, all. Welcome all to our monthly session of the Indian Society of Journal Club. Along with me, I have my co-moderators, Dr. Arun, Dr. Vivek, and Dr. Shyam Bansal from the Indian Society of Nephrology. I also welcome our panelists for today, Dr. Padmanabhan sir from Bangalore and Dr. Swanalata madam from Hyderabad. We are also joined by Dr. Arpita Ghosh from the George Institute, our lead statistician for the group from the George Institute. Before we start, I want to express the condolences from the Indian Society of Nephrology for the death of Professor George Bakris, who was one of the authors for the study we would be presenting today. So condolences from our team. And I would now invite Dr. Prasoon Sebastian, our senior resident from Government Medical College, Calicut. Prasoon, if you're ready, shall we go ahead?
Thank you, sir.
Yeah.
Good evening, all of you, respected faculties and dear colleagues. So today we are for our monthly journal club on the study FLOAT trial. It is actually the effect of semaglutide on chronic kidney disease in patients with type 2 diabetes. So more than 500 million people are affected by chronic kidney disease. And we know type 2 diabetes is the most frequent cause of CKD. Glycemic and blood pressure control are the key to retard CKD progression, for which we have RAS inhibitors, SGLT inhibitors, finerenone, which are shown to be protect the kidneys and reduce the risk of adverse cardiovascular outcomes. but still there remains a major unmet medical need to improve the treatment of CKD in patients with diabetes. So here comes the role of GLP-1 receptor agonist. It has multiple action to reduce the blood glucose level. It inhibits the growth of pancreatic beta cells. It inhibits production of glucagon. It slows digestion, reduces body weight, reduces appetite, and it's actually an mimic effect of incretin. So regarding the GLP-1 receptor, it is a G protein coupled receptor, which is predominantly expressed in pancreatic beta cells, but it is also expressed at lower levels in several brain regions, heart, endothelial vascular tissues, and even in kidneys. So as we can see, depending upon it has multiple site of action. In the liver, it increases the glycogen storage, and it has some protective effect in the brain. And in the heart, it increases the myocardial glucose uptake. It decreases ischemia-induced myocardial damage. As mentioned, in pancreas, it increases the beta cell formation and it decreases beta cell apoptosis, increases insulin biosynthesis. And in skeletal muscle, it increases glucose uptake. In blood vessel, it has increased endothelium-dependent vasodilatation. And even in fat cells, it increases the glucose uptake, increases lipolysis. As we can see, this receptor is seen at multiple sites and has multiple action at these different sites. So coming to the GLP-1 receptors in the kidneys. So some of these receptors are present in kidneys also, and studies have found that intrinsic kidney and immune cells contain the GLP-1 receptor, and this GLP-1 receptor agonist can reduce cellular expression of pro-inflammatory and pro-fibrotic mediators, and direct effect of this receptor agonist on the kidney may include a decrease in inflammation, oxidative stress, and fibrosis. So because of these proposed mechanisms, there might be a direct benefit for kidney with these drugs. So we have different options of GLP-1 receptor agonists, which include dulaglutide, exenatide, liraglutide, lixisenatide, and semaglutide. And our interest is on semaglutide, which is available in both oral and subcutaneous forms at multiple doses, which is used in different studies. So till now, different studies have been done on this GLP-1 receptor agonist, and multiple studies have been done on semaglutide drug itself. And they found that in type 2 diabetes, the mean HbA1c was decreased by 1.0 to 1.5% with the use of 0.5 mg weekly, or 1.5 to 1.8% with the use of 1 mg dose, subcutaneous dose weekly. And because of these beneficial studies, in 2022, ADA recommends GLP-1 receptor agonist as one of the first-line therapy for type 2 diabetes. Similarly, studies done in obese patients, they found that there was a mean change in body weight from baseline to week 68, which was 14.9% of reduction in weight in the study group comparing to only 2.4% in the placebo group. And they have found a cardiovascular benefit in the form of that semaglutide showed 20% reduction in 3-point MACE and 21% reduction in the oral with the oral drug. So because of this beneficial effect of multiple studies, recently, 2 months back, FDA approved semaglutide to reduce the risk of cardiovascular death, stroke in obese or overweight adults. So now come to the effect of semaglutide on CKD with type 2 diabetes. So till now, we have found that it helped achieve a glycemic control, it helped in weight reduction, and multiple studies have proved the cardiovascular benefit. So how this drug will act on kidney and what are the kidney benefits which we can expect? Naturally, we will expect kidney benefits because it addresses few problems which are seen in CKD patients. One is hyperglycemia, weight, obesity, as well as the cardiovascular mortality and morbidity. So till date, there has not been a completed kidney outcome trial for GLP-1 receptor agonist. And cardiovascular outcome trials have included patients with the GFR as low as 15 ml per minute with secondary outcomes for kidney disease. In a meta-analysis of 7 cardiovascular outcome trials, GLP-1 receptor agonist reduced the risk of composite kidney outcome, which include macroalbuminuria, eGFR decline, progression to kidney failure, or death from kidney disease by a 17%. So in this background, we are going to a dedicated kidney outcome trial, that is the FLOAT trial, which was published in last month in NEJM. So coming to the FLOAT trial, that is to assess the efficacy and safety of subcutaneous semaglutide at a dose of 1 mg sub-Q once weekly for a prevention of kidney failure, substantial loss of kidney function, and death from kidney-related or cardiovascular causes in patients with type 2 diabetes and chronic kidney disease. So the primary outcome events are time to first occurrence of composite endpoint, which consisting of onset of a persistent of more than 50% reduction in GFR comparing to baseline, or onset of a persistent GFR of less than 15 ml per minute, or initiation of chronic renal replacement therapy, renal death, or cardiovascular death. So these 5 were the primary outcome events in this study. And secondary outcome events were an annual rate of change in GFR, time to first occurrence of a major adverse cardiovascular events consisting of non-fatal MI, non-fatal stroke, or cardiovascular death. And third point was time to occurrence of all-cause death. So it was a multi-center study which was in 387 sites in 28 countries, double-blinded and randomized placebo-controlled study. So the recruitment period was from June 2019 to May 2021, and trial was completed in January 9, 2024. The funding was done by Novo Nordisk. Coming to inclusion criteria, age more than or equal to 18 years who were diagnosed with type 2 diabetes and having an HbA1c of less than 10%. With renal impairment, which was defined either having a serum creatinine-based GFR between 50 to 75 and having a urine ACR between 300 to 5000, or a serum creatinine-based GFR of between 25 to 50 and with a urine ACR of between 100 to 5000 milligram per gram. So these patients were already on maximum tolerating dose of AC inhibitors or ARBs, and this dose was stable for at least 4 weeks prior to recruitment of study. And patients who were not receiving RAS inhibitors because of side effects were also included in this particular study. And exclusion criteria which include congenital or hereditary kidney disease like polycystic kidney disease, autoimmune kidney diseases, congenital urinary tract malformations, and use of any GLP-1 receptor agonist within 30 days prior to screening, or recent MI, stroke, hospitalization for unstable angina or TIA. And they have also excluded patients with NYHA class 4 heart failure and who are planning coronary carotid or peripheral artery revascularization, or who have taken KRT within the past 90 days, or uncontrolled or potentially unstable diabetic retinopathy or maculopathy were also excluded. So coming to trial procedures, the participants were randomly assigned to 1:1 ratio to receive either a controlled semaglutide group or a matching placebo. The use of SGLT2 inhibitors and MRAs were permitted, and the randomization was stratified according to the SGLT2 inhibitor use at baseline. And they have used an 8-week dose escalation regimen, which that is 0.25 mg per week for first 4 weeks, and if it is tolerated, then 0.5 mg per week for the next 4 weeks, and followed by a maintenance dose of 1 mg per week throughout the study period. And the trial duration was up to 3 to 5 years, and in this study, it was median follow-up period was 3.4 years. Coming to statistical analysis, it is a difficult part to digest. Thankfully, we are a statistician. I will just read this part. This trial was event-driven, and it was calculated that a minimum of 854 primary outcome events would provide a 90% power to detect a 20% lower relative risk in the drug group comparing to placebo group. And the efficacy analysis were based on the intention to treat principle, and they included all unique participants who underwent randomization, irrespective of adherence to semaglutide or placebo or changes to background medications. So time to first event outcomes were analyzed with stratified Cox proportional hazard model. And for the primary outcome, the hazard ratio, 95% confidence interval, and p-value were adjusted for the group sequential design with the use of likelihood ratio ordering. The EGFR slope was analyzed with a linear mixed effect model with randomization assignment. So coming to the study, there were around 5,581 patients were screened, out of which 2,042 had screening failure, and a total of 3,533 patients were randomized. They were randomized ratio of 1:1 to the semaglutide group and the placebo group, with having a 1,767 patients in the semaglutide group. An interim analysis of efficacy was planned after 2/3 of primary outcome events has occurred. So they were expecting a primary outcome event of around 840 events. So the pre-specified interim analysis was triggered in October 2023 after approximately 570 primary events had occurred. So based upon this interim analysis, they recommended an early completion of trial, and the trial was completed in January 9, 2024. Until that date, a total of 741 events were occurred. So coming to the results and discussions. So these were the baseline characteristics of this study population. They have done a good randomization that the baseline characteristics were equal in both our drug group as well as in the control group. But few things I would like to mention is that the proportion of patients, that is the female patients, was only 30% in the study group. And similarly, the black population was only 4.5% in the study group. And the patients were having a relatively controlled glycemic status because they were only including patients with the HbA1c of less than 10, and the average HbA1c was 7.8. But one thing is that majority of patients were obese in our study group, that the mean BMI was 32 in our study group, as well as the body weight was around 90 kg in the both study group as well as in the control group. And they have a relatively well controlled BP. So the mean GFR in our study population was 47, and there was a significant good number of patients with a GFR of less than 30 ml. That was around 11% of patients. And in the study population, they have capped the limit of patients with a GFR of more than 60 to below 20%. This is because they were expecting a primary event, and it is naturally the patients with higher GFR is less likely to have the primary outcome event. So they have capped the patients with GFR of more than 60 as 20%. Surprisingly, they have a few patients with normal albuminuria also. I don't know how it come, because in the study inclusion criteria, the minimum cutoff for the urine ACR was 100, but still there are few patients with normal albuminuria. One disappointing thing of the study was the patients who were taking SGLT2 inhibitors at the time of study was only 15.6%. However, majority of the patients were taking either AC inhibitors or ARBs. That is, around 95% of patients will be either on AC inhibitor or ARB. Patients who are on both AC inhibitors or ARBs were excluded from this study. So coming to the results. So we're having 5 major primary outcome events. That is, one is decline of more than 50% of GFR, or initiation of KRT, or a GFR decline to less than 15 ml, or cardiovascular death, or other kidney related death. So the primary outcome events occurred less frequently in the semaglutide group. There were 331 first events in the semaglutide group, where there were around 416 events in the study group, control group. So it shows that there is a 24% lower relative risk of primary outcome in the semaglutide group, which was found to be statistically significant. So this orange color is for the drug group, this blue color shows the placebo group, and we can see that as time progresses, there is a difference between the semaglutide group and the placebo group because of the reduction in the primary outcome event in the study group. So coming to kidney specific component, that is basically the decline of GFR less than 15, or 50% decline in GFR, or kidney related cause of death, or initiation of KRT. So we can found that the hazard ratio is 0.79, and there is a difference between this placebo group and the semaglutide group, and this difference was much pronounced taking the death from cardiovascular cause itself. That is, the hazard ratio is 0.71, with a significant decline in death from cardiovascular cause in the study group. So coming to the secondary outcomes. So one secondary outcome they assessed were the eGFR decline, and they found that the mean annual GFR slope of the eGFR was significantly less steep in the semaglutide group comparing to the placebo group. So in the drug group it was 2.19, and in the study group, in the placebo group it was 3.36. There was a decline of difference of 1.16 between the semaglutide group and the placebo group, which was also statistically significant. But two things which we have noticed in this study is that the initial phase of study, that is up to 12 weeks, there is a more decline in the GLP-1 receptor agonist group comparing to placebo, as we see with initiation of RAS inhibitors or even with SGLT inhibitors. And similarly, the maximum difference between this semaglutide and the placebo was seen by the second year to third year, and following which we can see that the difference actually get narrows. So we doesn't know on further continuation of this drug or further continuation of the study whether this will come together again. So that's two things I would like to mention here. And regarding the first major cardiovascular events, that basically include non-fatal MI, non-fatal stroke, or death from cardiovascular, and they're shown that there is a risk of major cardiovascular event was 18% lower in the semaglutide group comparing to the placebo group. And on death from any cause, the risk of death was from any cause was 20% lower in the semaglutide group comparing to placebo group, even though it was not statistically significant. And even this death from the cause, majority was from death from cardiovascular cause only. So coming to other secondary outcomes, one is urine ACR ratio to baseline, and we can see that there was a reduction of around 40% reduction in urine albumin creatinine ratio on starting the treatment, and this effect was seen within 26 weeks of starting the treatment, and this difference was maintained throughout the study period. Similarly, a decline in body weight was seen in patients who were taking semaglutide, and the difference was seen actually by 1 year of initiation of treatment. There is a decline of around 4 to 5 kg of decline in weight can be seen, and this difference was maintained throughout the study period when these patients were taking drugs. Similarly, a reduction in HbA1c, which we are naturally expecting, was seen with the semaglutide group, and there was a minor difference in the systolic blood pressure in the semaglutide group comparing to the placebo group, and this difference was actually maintained throughout the study period. But this difference was not reflected in the case of diastolic blood pressure. As we can see, the diastolic blood pressure was slightly higher in the treatment group comparing to the placebo group. So these were the primary and secondary outcome events in a nutshell. So which we can see the numbers. So as mentioned, the primary outcome event occurred in 18.7% in the semaglutide group with 23.2% in the placebo group, and this difference was statistically significant. And this difference was mainly driven by two factors. One is a decrease in death from cardiovascular cause with a hazard ratio of 0.71. Another thing was a reduction of more than 50% from baseline GFR. So these were the two major contributors to make this study the statistically significant portion. Regarding the other components of the primary outcome, that is a GFR of less than 15 or initiation of kidney replacement therapy or death from kidney related causes, it was not much different. It was 5.2 and 6.2, 4.9 and 5.7%. Now coming to the secondary outcomes, as we have mentioned, there is a difference of 1.16 annual GFR rate between the study group and the control group. And regarding other cardiovascular events, we can see that there is a 18% reduction in the cardiovascular events in study group comparing to placebo group. However, we can see that the non-fatal stroke was higher in the study group comparing to placebo group, which could be a slight aberration. And coming to the secondary outcomes, as mentioned, the ratio of urine ACR at the week 104, it was to the baseline was 0.60 in the study group and 0.88 in the placebo group. And the difference in body weight, it was 4 kg in patients on the study group comparing to the placebo group. And we have seen that in the initial phase of starting treatment, there was actually a higher decline in GFR comparing to placebo group. But when we look at the numerical value, it is only very slight difference. It is minus 1.07 in the study group and it is minus 1.05 in the placebo group at the end of week 12. But still, with a 3-month period, it is a high value. And the mean change of GFR by cystatin's equation from baseline to week 104 was minus 2.1001 in the study group and minus 5.41 in the placebo group. That is a difference of 3.39 ml per minute per 1.73 meter square was obtained when study was done for 2-year period. And severe hypoglycemic episodes were also comparable in both the study group and the placebo group. So at the 104 weeks, that is at end of 2 years, the urine ACR ratio was reduced by 12% in the placebo group as compared with 40% in the semaglutide group. And loss of kidney function as indicated by cystatin C based GFR was lower by 3.39 ml per minute in the drug group comparing to the placebo group. And at 2 years, the mean reduction in body weight was 4.10 kg greater in the semaglutide group comparing to placebo group. So now coming to the serious adverse events. Actually, there was 50% of patients had some serious adverse events were reported in the study group, which seems quite high. It seems like they have included all the events in the study. So few which we were interested was diabetic retinopathy. It was earlier considered that this drug may worsen the diabetic retinopathy, but we can see that the adverse event mentioned here is almost equal in study group and the control group. Similarly, other concern was regarding hypoglycemia, and we can see that it is equally same in the semaglutide group and the placebo group. And there was also a concern regarding pancreatitis also, but it is a very minor adverse effect reported here, and also not very higher than the placebo group. So we can find that the serious adverse events reported in the study group was 49.6%, and in the placebo group it was 53.8%. That is higher adverse event with a placebo than a actual drug. So this fewer participants in the semaglutide group were reported to have serious infections or infestations, as well as serious cardiovascular disorders. So because of this, the serious adverse events were reported less in the study group than the placebo group. Now coming to adverse events which leading to permanent discontinuation of drug or placebo were found to be more common in the semaglutide group than the placebo group, which was 13.2% in the study group and 11.9% in the placebo group. And it occurred primarily because of the gastrointestinal disorders. So as we can see, there were a total of 79 gastrointestinal disorder with the semaglutide drug and only 20 with the placebo group. And the main events were nausea, diarrhea, vomiting. And 5 patients have been discontinued because of pancreatitis, and 4 patients had constipation also. So all other events were actually comparable between both the study group and the placebo group. And we know the beneficial effect of this drug on decrease in weight. So one thing which we are interestingly found is that 7 patients have discontinued semaglutide because of decrease in weight. And surprisingly, 4 patients in the placebo group also had a loss of weight. And they have discontinued medication because of loss of weight. Now coming to subgroup analysis of primary outcome events. So actually, the primary outcome events between these different subgroups were actually comparable. And we know there were a large number of patients with a higher BMI, and it seems that patients with a higher BMI have a better effect. And similarly, the patients with age more than 75 seems to have a better effect, but may not be statistically significant. And similarly, one important thing to notice is that the proportion of patients who were taking SGLT2 inhibitors were very less. So in the very few patients who were taking this drug, there was no benefit with semaglutide. So on analyzing the result, we can say that semaglutide at a dose of 1 milligram once weekly significantly reduced the risk of major kidney disease events, the risk of cardiovascular events, and it slowed the annual loss of kidney function by GFR by 1.16, and it reduced death from any cause. So how we can extrapolate this result to our real world situation? So we know that there are few medications which are already found to be beneficial in diabetes and CKD, and it is already approved for the same. They are the RAS inhibitors, SGLT inhibitors, and the newer MRAs like Finerenone. For our study, they were saying that RAS inhibitors must be taken for all patients unless they cannot take it because of side effects. And patients were permitted to take SGLT inhibitors, and SGLT inhibitors was a factor criteria for while randomization also. So around 95% of study population were on RAS inhibitors, but only 15% of patients were taking this SGLT2 inhibitors. And on subgroup analysis of these fewer patients, we found that there was no any benefits. So combination therapy is likely to be important in future, and hence further studies are required combining our GLP-1 receptor agonist and SGLT inhibitors to prove its efficacy. And also other concern is that use of non-steroidal MRAs were not a criteria while randomization, and might be the patients who were taking this drug were very less. And another concern which I found is that the patients, as you can see in this chart, patients having a normal BMI was only 11.5%. That is the patient with a BMI of less than 25. And around 30% of patients were either overweight, and the majority of patients, that is more than 50% of patients, were actually obese. So we have multiple studies which were done on these overweight or obese patients, and the benefit was already proven. So, and also our study shows that there is a trend to have a better outcome with a higher BMI than a lower BMI. So majority of our patients have a nearly normal BMI. Majority of our diabetic patients have a nearly normal BMI. So the benefit of semaglutide in patients with a normal BMI is questionable. And other thing is that modest weight loss could also lower the serum creatinine levels. But they found that there is identical effect on cystatin C based creatinine GFR as well as creatinine based GFR. which indicate that this difference is unlikely to influence the result. But fewer studies show that weight loss could also decrease cystatin C level. But majority agrees that weight BMI has less an effect on cystatin C. So it is another questionable doubt that whether weight loss has influenced our trial result. Another concern is that this analysis were done by the sponsors, even though they mentioned that data were verified by an independent biostatistics consulting company Statogene. So coming to strength of our study is that they assess clinically important outcomes. Significant benefit was found for kidney and cardiovascular outcomes. And it was a large and rigorous study. Some limitations is that, as we have mentioned, use of SGLT2 inhibitors and non-steroidal MRIs were modest. And there is underrepresentation of Black population in the study. The trial was not powered to detect differences within and between important subgroups. So that's all regarding the study. I'm also happy to share with you that our college, Calicut Medical College, was also a part of the study. It was one of the recruiting sites from our country. And actually, it was the highest recruiting site among all other 387 sites. Around 78 patients were screened from our center, and 50 patients were randomized from our college. Thank you, all of you.
Thank you, Dr. Prasoon, for a very nice presentation. And congrats for being the highest recruiter in India. So I think before we start discussion of this, of the journal per se, I would like to invite Dr. Arpita Ghosh, who's the head biostatistician and data science in George Institute, to go on to the statistical aspects, and then probably we can discuss the journal as a whole. Dr. Arpita Ghosh, please. Prasoon, you will have to stop sharing.
Thank you, Dr. Arun. I'll try to share the screen.
And I would like to request all the participants to put your questions in the chat box, and we can probably take it up after the JC discussions by the panelists.
Are you able to see my screen?
Yes, ma'am, it is visible.
Hi. I was asked to present a few slides on stratified randomization. I somehow feel that I may be speaking to the, you may already know quite a lot about it. So please pardon me if this is a repetition of what you already know. This is quite basic. I'll start with randomization. Are you able to see the full screen and not the, I hope it is not the presenter view.
No, we need to see the screen.
Okay. So very quickly, I'm going to start with randomization. So we generally, in a trial, we want to test whether a new treatment, as in this trial that Dr. Prasoon presented, whether a new treatment works better or worse than usual treatment. Now, if you join a trial, a computer will be used to randomly assign you to one of the groups. And we use chance to determine which group you will be allocated to. This is randomization. And this will help ensure that the mix of patients in the two groups are as similar as possible, as we saw in this presentation. Now, if one did not randomize and selected patients, it may so happen that, for example, elderly and smokers got the new and promising treatment, and say, for example, the young and the non-smokers got the usual treatment. Then we may not see any difference, but that just may be due to the patient mix in the two groups. Now, it is easy to see age, observe age and smoking status, so we may be able to adjust for those in the analysis. But there may be several other things that may be different between the two groups, and we may not be able to observe. How to ensure that the two groups are similar? Randomization ensures precisely that the two groups are similar with respect to prognostic factors at baseline. And these prognostic factors may be known or unknown. So if we do simple randomization, are we able to ensure this, that the two groups are similar with regard to the baseline characteristics that influence prognosis? Simple randomization may not be able to ensure this. Why? Let's see. Say, for example, we have a prognostic factor with a 15% prevalence. Now, we would want this prognostic factor to be present in similar proportions in the two arms. But if we have a small sample size, as we see in this table, that if we have a very small sample size, the difference in proportions in the two arms, that it is greater than 10%, that probability is quite high if the sample size is low. And it reduces if we have a larger and larger sample size. But for a small sample size, we run into the risk of having imbalance with respect to this very important prognostic factor. Now, this chance of imbalance becomes even higher if you have a prognostic factor which is even more prevalent. So through simple randomization, we may not be able to ensure that the two groups are as similar as possible with respect to these critical features. Stratified randomization helps us ensure this. Now, what happens in stratified randomization through this simple graphic is we have our patients and we try to identify factors which are critical features that are related to the outcome. Now, say, for example, here we have these dots and these pointy shapes. Say, for example, that is the prognostic feature that is also related to outcome. Now, we divide on the basis of that, we divide it into two strata, and within each strata, we then randomize. So what that does is, if we now look at arm 1 and arm 2, we see that it is equally, the prognostic factor is equally distributed. We have both those pointy structures and the circles in both the arms in equal proportions. So that helps ensure that if you have a factor that is really important and connected to the outcome, that is equally distributed between the two arms. As an example, say, for example, we have a phase 3, parallel arm trial, placebo-controlled. The sample size is 400 patients. Now, in terms of randomization, we have mentioned that we want to have a 1:1 allocation ratio, and we want to have a stratified randomization. So how do we operationalize it? Say, for example, the factors are, it's a multi-site study. So there are 10 sites, 10 hospitals. So each site is one factor. Hospitalization status at the time of randomization, that can be one of the factors. Say, for example, body weight. So there are 3 stratification factors that we think may be related to the outcome, and we want to stratify on the basis of that. So how do we go about it? In terms of implementation, so the strata then becomes a combination of the site, hospitalization status, and the weight, whether it's less than equal to 70 or more than 70. So in terms of number of strata, because we have 10 sites, 2 levels of hospitalization and 2 levels of this weight categorization, we have 40 strata. So for example, if we have a site, in each site, then we have a 2x2 table. And once a patient comes in based on these 2 factors, we're able to place the patient in one of the cells. Now the question is, which arm should the patient then be allocated to, A or B? The way we do it is, for each of these 40 strata, we generate a randomization list and allocate the patient to the arm according to that list. Now, generating this randomization list is very easy because for each of these positions, there is an equal probability of A or B appearing. So you generate a long list, and every time that a patient comes in, according to that allocation, random allocation generated by a computer, you assign that patient to that list. Now, this is supposed to ensure that your prognostic factors are equally distributed between the 2 arms. Are we able to do that? Say, for example, in this site, we recruit 10 patients. So after recruiting 10 patients, we see that 3 goes in arm A or 1 and the other 7 in arm 2. Now, it's clear that, we will not be able to, there is an imbalance because in the long run, it's supposed to be equally distributed. There's a 50% chance of every position being occupied by A and B. But at every point in time, we cannot ensure that the balance is there. So in case of a small sample, the chance of an imbalance is very much there. So how do we avoid this? So stratified randomization is often combined with a block randomization, a permuted block randomization. What is that? So we randomize in blocks of patients. So usually these are of sizes 4 and 6. Within each block, we fix the number of, we are going to have 2 A's and 2 B's. So equal number of patients receive each treatment. So we always randomize in blocks of 4. So these are the possible permutations that you can have with 2 A's and 2 B's in block sizes of 4. Now, when a patient comes in, they receive the next treatment in the current block. So what happens is, every time at the end of each block size, you have an equal number of A's and B's. And at any point in time, the difference in the number of patients in arm 1 and arm 2, it will not be more than 2. So that way, by ensuring that you have this fixed block size, by combining the stratified randomization with block randomization, we ensure that in my 2 groups, the important prognostic factors are balanced. So when we combine the 2, we generate a list for each of the. So for the 40, we had generated a long list. Now, instead of that long list of A's and B's, we generate a list for each of the 40 strata, but it's in block sizes of 4. Now, if we look at this, it's easy to, after a while, it's easy for the investigator to guess that the block size is actually 4. And if you're able to guess the block size, then it becomes quite evident that the third letter, once, in a block, the first 2 assignments are B, B, it's easy to guess that the next two are going to be 1. Or, the fourth one, once you have assigned the first 3. So allocation concealment, which is also a very important property of the randomization, then that is at stake. So what we do here is, instead of fixing the block size, a common thing to do here is to vary the block size. So instead of fixing it as 4, we can have a variable block size of 4, 6, and 2s, and then the allocation concealment becomes much more feasible. So that is all that I have on this topic. I'm happy to answer any questions on this. I'll stop sharing.
Thank you, Dr. Arpita. I think we'll take the questions as and when they come. So now I'll request Dr. Padmanabhan sir and Dr. Swarnalata ma'am to initiate the discussion.
Good evening. Thank you for giving the opportunity. I would like to initially congratulate the ISN Council members for conducting such a good academic feast with pertinent topics. And I think this is a very important topic for all of us. And I would like to really appreciate the presenter, like he has covered the entire aspect very clearly, and including what are the strength and weakness of the study. So coming to the semaglutide, I think it is a new kid on the block. And as with the previous studies, like in the last era, we have all learned about the SGLT2 inhibitors and MRAs. I think this would be the game changer in next coming years in terms of management of CKD, particularly with respect to type. Previous new molecules, they were actually designed to study on the cardiovascular benefits. And so also this molecule, it was actually initially designed, as has been mentioned by the Prasoon, that it was actually designed for the glycemic control, the obesity, the weight reduction, and the cardiovascular benefits. But one of the major meta-analysis with around 96 studies, they have shown that there is a post hoc analysis showed that there is a beneficial effect in terms of the renal outcome as well, and that has led to a flow trial. And the strength of this would be like it's a very large trial, and the results are very clear. It has shown that there is a beneficial effect of 24% reduction in the kidney outcomes. And of course, there is less steeper decline in the eGFR, and with beneficial effect on the major cardiovascular events and all-cause mortality as well. Of course, they are too concerned about this because this study was started when there was no recommendations to use the SGLT2 inhibitors and MRA, and very few percentage they have represented in this trial as well. So I think that is a major concern, and with so many molecules now available, the confusion is what should be the priority, which should be started first, and then what should be added on, what best combination should be used in which patient profile, like cardiovascular or the kidney or obesity. So as has been mentioned, like obesity, majority of the patients were obese, and And these are only short term. The average follow-up was only 3.4 years. So we should look at the other patient profile, like patient with not so obese, and what will be the long-term outcomes of these patients. So these are my inputs, and I would like to invite my co-panelist, Dr. Padmanabhan, to comment.
Yeah, thank you, Dr. Swarnalatha. Thanks, the ISN, for this opportunity. I think it's a wonderful learning opportunity for all of us, especially the PGs. Very good presentation indeed by Dr. Sebastian. I look at it in a slightly different way. When we look at progression of chronic kidney disease in patients with diabetes, or let us take it as diabetic kidney disease progression. Till 80s, I think the GFR decline was close to about 10 mils per minute per 1.73 square meters per year for all our patients, because we were only relying on glycemic control as a process of retarding the progression of chronic kidney disease. Now, once the ACE inhibitors came in, I think we saw a decline in the rate of decline of GFR from about 10 mils per minute per year to about 7 or 8 mils. And then it went further down to about 6 or 5 when the ARBs came in somewhere around 2000s. And then with the SGLT2 inhibitors, it went down to around 3 mils per minute. But then we are nowhere near the 0.8 or 0.1 mil per minute per year decline of GFR, which is attributed to the normal aging process. Now, the question is, how can we narrow this gap from, say, the current 3 mils per minute decline in GFR to about 0.8 or even 1 is very acceptable. So I think this is the quest for us, and then these drugs are taking us towards that particular goal. I think we should look at it in that particular angle. Having said that, the issue is we have reached a particular level of around 3 mils per minute retardation, which is reasonably good enough and closer to the normal aging-related decline. But what will happen when we combine all these things? So supposing we add an SGLT2 or a finerenone with the semaglutide group of drugs, is it going to take us towards the target of a 1 mil per minute decline per year? Now, that is a question that we need to answer. And I don't think the answer will come very soon, because these drugs are there in the market for hardly about a few years or so. And I think they very rightly said that by the time we started randomization for the semaglutide trial, SGLT2 and finerenone were not supposed to be the state-of-the-art treatment for diabetic kidney disease. And probably that is why we had very less number of people with SGLT2 inhibitors in the study. The other interesting aspect is that those who were already on SGLT2 inhibitors, it said that semaglutide probably did not add an extra benefit. If you see the slide which he had shown to us, probably I think we'll have to wait for some more time. Now that we'll have more and more people who are on SGLT2 inhibitors, and then we will be adding semaglutide, both the subcutaneous version and the oral version, which has come now. I think we will have to wait to see the outcomes of a combination of 1 or 2 or 3 of all these things, depending upon the clinical situation. Then the third thing is there are 3 arms of diabetic kidney disease progression. One is the hemodynamic arm. The second is your glycemic control arm. And the third is inflammation and fibrosis. Now, probably RAS was not able to do all those things because it did not block the aldosterone, and that caused progression of fibrosis. So maybe the mineralocorticoid receptor antagonist would be an answer to that. And probably we'll have to see what exactly is the mechanism of action. Is glycemic control resulting in a reduction in inflammation because of diabetes? Because diabetes is a pro-inflammatory state. Then obesity is reduction of weight is translating into reduction in the inflammatory markers, or is that what is helping semaglutide to achieve these targets? I think we will have to wait and see. So now I think we are in an era where we have medicines which can target all three aspects of diabetic kidney disease progression. So I think this is one of the important steps that we have taken in terms of this particular trial and the other trial which had come out with oral semaglutide also. So I think we'll have to wait for some more years, as Dr. Swarnalatha said, to see what exactly is the result of all these medications in terms of what we give to our patients with chronic kidney disease. I think we can
Yes.
take questions now.
Yes, sir. We have few questions in the chat box. So, first was, please enlighten on its safety in CKD stage 4. These patients, I think even Darshan has already answered that. This trial included patients with a GFR of 25 to, I believe, 70 ml per minute. So this has definitely included patients with the stage 4. And of course, as has been described, it was safe, and then the side effects was less, documented in patients with semaglutide compared to the placebo group. So it appears to be safe, and of course, the major concern was the GI intolerance, and that was the cause for the permanent withdrawal in this group. So I think it can be safely administered in people with stage 4 CKD.
One of the comments from Dr. Satish was the graph of eGFR slope shows a highly significant p-value, but the CI crosses unity. Is that possible? This is for Dr. Arpita Ghosh. Looking into the stats part of it.
Will you please show me the graph if it's possible? Because it's not possible, it seems. The p-value and the confidence interval should have a one-to-one mapping. So just want to make sure.
Person, can you go back?
Just a second. The slide is not working
now. Can you just further elaborate, Arpita, on the, I said one of the comment I passed on was only 15% were on SGLT2 inhibitor, and stratification was still based on 15% population. I could see your comment. Would you mind elaborating till the slides?
Sure. Yes. So here, if SGLT2 is the stratification factor, then within that 15% would get distributed in the two arms. And so what will happen is, because its prevalence is not very high, you would not want all of them to end up in one arm. It is an important prognostic factor. So given that it's a small number of people, if they think of the situation where you not use the stratification, you run the risk of them ending up mostly in one arm versus the other. You would want to prevent that scenario.
Okay.
So within that 15% would get split up in the two arms. So you would make sure that they're equally represented in the two arms.
Okay.
So the fact that it's less than the proportion that you had, that the investigators had expected when they began the experiment, it's even more pertinent because it's a small number of people. Easily they could land up more in one arm than the other. So it makes even more sense to stratify based on that prognostic factor.
Right. But with 7% in each arm, let's say we have stratified and with 7% in each arm roughly, with such a small sample, would the results actually would it make sense with such a small sample in each arm, and then coming out with a statement saying that in the group where SGLT2 was inhibitor, semaglutide did not show any added benefit? That was the conclusion.
Right. I was also surprised to see the stratified analysis. Usually, if I have a stratification variable, the appropriate way to account for it in the analysis is to adjust for it as a covariate when I'm doing the Cox proportional hazards regression as they've done here. But to do a stratified analysis, I would imagine that you would need a much bigger sample size in each of the two strata. So I was also surprised to see that they did a stratified analysis instead of having that as a covariate in the regression, which I think they did it in a subsequent analysis, but the primary one that they have mentioned is a stratified one. So the stratified one would be a problem, but then including the stratified variable as a covariate, that will not pose a problem with that 7% in each group.
Yeah.
Yeah. So one
Yeah.
question can I ask the panel? See, this is an intravenous drug, and we don't have this in India yet, probably, and we have this oral formulation. So can we extrapolate result from this trial, and we can use the oral formulation? Would it be give same effect?
Can I answer this question?
Yes, yes, yes.
Yeah.
Yeah, Dr. Sharma.
So, look, oral formulations, basically they have this, first is intolerance, GI intolerance, they don't tolerate. And that was the reason for patients like withdrawal of the drug. The second thing is like, this is a first pass effect will be there. So bioavailability is very less. That's the reason why, the subcutaneous or the intravenous dosage was considered rather than the oral. But if you look at oral, it should be given daily, and we don't know the cost effectiveness of all this stuff. It has to be given in larger doses, and then because of the decreased bioavailability. But however, they said that if it has to be given orally, it has to be daily doses, so to have a the better effect, beneficial effect on kidney disease.
Yeah, so that is still not proven. So we really actually can't use the drug which we have in India right now. And secondly, obviously the cost is a very important factor because this is a costly drug, even oral. I don't know about the cost of IV. It should be actually costlier than the oral formulation. And again, this question comes that if you see SGLT2 inhibitors alone over the ACE inhibitor ARB, the benefit is more. Even if you see that there is a renal endpoint reduction is 30 to 40% as compared to 20-25% with this medicine. So we can't really say that this drug, if in combination, how much it will be useful. And again, the most of the patient, probably the obesity, the one of the situation where this drug could be used more commonly, and some of the benefits were very difficult to comment is because of the weight reduction, and that actually led to some reduction in proteinuria or slowing the progression. What is your other panelists' comments on that?
Yeah, see, there is a trial on oral semaglutide in chronic kidney disease. It also says that it preserves the GFR, but I don't think it is that significant compared to the subcutaneous version of the semaglutide one. Second is that I do not see if this is going to make a major difference in terms of renal outcome. It may make a difference in terms of weight reduction and cardiovascular outcome. So I think SGLT2 probably would be the game changer for renal disease rather than semaglutide. I mean, this is what my thought process is. Whether adding semaglutide is going to make a much larger difference to the outcome in terms of GFR preservation, I think we'll have to wait and see. Given the cost of the drug, I think the tablet, a 14 milligram tablet, it's around 350 rupees is what they told me, because a couple of my patients have been prescribed this particular drug on a daily basis. They have a very good glycemic control, but they're all having normal renal function. So I am not very sure about use of semaglutide in patients with chronic kidney disease with the aim of preserving eGFR, but I would probably fall in for the SGLT2 and the finerenone, unless the diabetes is very difficult to control in all these people.
So I agree with you. So in fact, there was another trial, step 1, 2, 3 trial. Here also, like patients were non-diabetic and obese, and they had a beneficial effect on reduction of the weight. I mean, primary focus, the primary endpoint was the weight reduction and the glycemic control. In fact, like step 1 and step 3 trial, they had patients who are non-diabetic as well. So it's predominantly there is definitely a clear-cut beneficial effect on the reduction of the weight and glycemic control. But when it comes to basically the renoprotective effect, obese patients is still it's a dilemma. I think we definitely need larger studies focusing on patients like who are not obese, where we can demonstrate the renoprotective effect. And of course, if you look at, I mean, all these have different mechanisms of actions. Like predominantly SG2 limiters are, it's because of the hemodynamic effects. And if you look at this semaglutide, it's like it's an insulin secreting effect would be there. So considering theoretically the different mechanism of action, I feel there could be some synergistic effect when used in combination. In fact, even for the glycemic control, they said that if first preference is metformin, if there is no poor glycemic control and they cannot tolerate, we can go for this semaglutide. And in fact, we can have a combination of all three, including the SGLT2 inhibitor, semaglutide, and the metformin. So I think this combination, of course, they look very promising, but we need a practical experience, and then particularly with respect to our population profile.
Dr. Arpita, I think the slide is there for you to, I mean, if you can see the confidence interval in the last two.
Yes, I can see. So here it's the mean difference. This is not a hazard ratio. So the mean difference, you see, it's 1.16 and it's consistent with the p-value. So the mean difference confidence interval does not include 0, which is consistent with the p-value, and that's what the text also says. So here it's a mean difference. It's not a hazard ratio. So the null value is 0. It's not 1. So the confidence interval is consistent with the p-value that's reported.
Thank you. If there are no more questions, I think we have reached the end of the session. It's 9 p.m. Thank you. Thank you all for joining in. Thank you, Dr. Padmanabhan sir. Thank you, Dr. Swarnalata. Thank you, Dr. Arpita, for your valuable insights on the statistics. And I thank all my co-moderators, including Shyam Bansal sir, for joining us in today. We'll see you in next month for the Journal Club, and hope you have a good night. Thank you.
Thank you. Thank you very much.
Thank you, everyone.
Thank you for that.